I'm thrilled to have you join me again tonight in this program on the pharmacology series for NP faculty, and hopefully to share some pearls that will help you out with teaching pharmacology. A little bit about my background. I am the founder of Fitzgerald Health Education Associates. My clinical practice has been in an FQHC for more than 35 years. Literally, my entire career as a nurse practitioner has been in primary care. And but it's primary care in an FQHC, so it's a mix of same-day urgent care and ongoing primary care. And I see everything that comes through the door. The little ones, the babes in the womb, all the way up till the older adult. I'm also adjunct associate professor at Case Western Reserve, which is where I did my doctoral studies. I sit on the editorial board of a number of different journals, and I'm also a member of the Pharmacy and Therapeutics Committee for a major HMO in New England. And one of the things I like to do when I'm teaching NP review are in teaching, which we've helped 180,000 nurse practitioners achieve certification. And when I'm dealing with newer NPs, sometimes people will say, that looks a little boastful throwing these things around. Plus, I'm like you guys, I do about 45 other things above and beyond this. One of the reasons I like to do that when I'm dealing with new NPs is to show them that it's what an amazing role the nurse practitioner role is. So a few things to mention here: no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented, off-label use will be identified as such if discussed. So what we're going to take a look at, and really we're looking at this through the lens of NP faculty, is completing the learning activities. The participant will be able to identify treatment goals in type 2 diabetes, especially in the presence of select comorbid conditions, describe the most appropriate medications in the treatment of type 2 diabetes, particularly in the presence of select comorbidity. And again, always highlighting those teaching moments. The references will be throughout the presentation. All right, so I have been privileged beyond all belief, to have been able to help people get ready for their NP boards for more than 35 years now. So that's great. That's great. And when it comes to teaching NP review, there are a couple of different areas where 99 times out of 100, what we've got is the person saying to me, oh, I can't make it through this. This is so confusing. This is so this is so that. The diabetes drugs just baffle me. So that's one reason why I wanted to tackle the diabetes meds early on in this series. And the ironic part about this is that, in my darker moments, what I want to say is, oh, could we just go back like 30 years when we had sulfonylureas and metformin and that was about it? And I say that in jest because, yeah, that's really, and of course we always had insulin. Of course, that was then, this is now. And what we now have is, instead of like 30 years ago, you didn't have people with type 2 diabetes who ended up being in their 80s, maybe 90s. Quite frankly, they were dead in their 60s and 70s, often with some really negative adverse effects, amputations, CKD, things like that, that certainly can happen now, but we've got so many things that are so much better for the treatment of type 2 diabetes. So one of the things is just to start off with the recommendation that the ADA says, this is really common sense. When you're choosing type 2 diabetes meds, consider patient factors as well as drug mechanism of action, safety profile, risk of hypoglycemia, cost, and potential non-hypoglycemic benefits. So what I do, and I have to tell you, this has really stuck with people, is the following. So this gets back to, if you were with me for the session I did on PK versus PD. This is exploiting or really conceptualizing pharmacodynamic PD principles. I find this works beautifully. Divide the drugs into 3 different groups. Insulin sensitizers, and the insulin sensitizers are metformin and the TZDs. So what they, of course, allow is for the body to utilize insulin better, whether it's exogenous insulin or endogenous insulin. Okay. And what's the core pathology with type 2 diabetes? It is insulin resistance. And then insulin releasers. And the 4 insulin releasers are the sulfonylureas, the DPP4 inhibitors, and those all have the gliptin suffix, like Januvia, sitagliptin was the first in the class. The GLP-1 agonists, they have a tide suffix on that. So that's a drug like semaglutide, Ozempic. Everybody knows what Ozempic is, and Wegovy. And the GIP, GLP-1 agonists, and to be honest with you, I kind of lump the GIP, GLP-1 agonist and the GLP-1 agonist together into one group. And the GIP, GLP-1 agonist is, there's only one in that class right now, and that's the drug tirzepatide or Mounjaro. Again, tide suffix on it. And then glucose offloader. Only one class in that, and those are the SGLT2Is, and they all have the gliflozin suffix. So I find when I'm teaching this, and I say to the students, so think it through this way. What is it you're trying to do? Are you trying to allow the patient to utilize insulin better? Then you're going to go with metformin or a TZD. Put a little asterisk next to the TZD because we don't use the TZDs with insulin because it increases heart failure risk. All right, the person has been optimally insulin sensitized. They're still not at A1C goal. What is that telling you? Then they need help insulin releasing. So then you decide, oh, sulfonylurea, DPP4 inhibitor, GLP-1 agonist, GIP, GLP-1 agonist. You're going to prescribe one of those. And then also looking at, is there a need for glucose offloading? So let's take a look at these meds with metformin. Now, you might have heard, and I've often had my people in class say to me, yeah, but I recently read that metformin's no longer a first-line drug for the treatment of type 2 diabetes, that others with certain comorbidities should be first line. No, what the ADA actually said is don't get rid of the metformin ever, but when people have CKD, when people have ASCVD, there are other meds you want to make sure they're also on. So metformin, something to remember when your students are getting ready for boards, there are questions on boards that reflect cost of medication. It's both cost and efficacy. Metformin is $4 a month. Cheap, cheap, cheap. Insulin sensitizer, how much can it bring down A1C? Considered to be one of the higher ones. So if you start with an A1C of 10, it's going to bring it down to 8 or 9. But if goal A1C is less than 7, which it is for most people, you know you're not there yet. You're not there yet. Now, low hypoglycemia risk, very well suited for people who eat on an irregular schedule, because low hypoglycemia risk. And why is that? Because it does not cause insulin release. Does not. Has nothing to do with insulin release. What metformin by itself is doing is allowing the person to utilize the insulin they make endogenously. Weight impact, which with all of them, except for a couple of the different meds, the weight loss is pretty modest as a general rule. But with this, it's neutral or weight loss. Something I point out to patients is once they're better insulin sensitized and their endogenous insulin levels go down, they often find they're a lot less hungry And so they're really, really, they're really excited about that. And they'll notice they naturally will lose, maybe 4 pounds, 8 pounds, something like that, without a tremendous amount of effort. Now, this is one of the things that we always hear about it is, metformin is tough on the stomach. Here's something amazing, and I find that people are fascinated with learning this out. That learning this. Metformin is a prebiotic. It increases healthy gut flora that then increases lower GI motility. And therefore, that's why there are the loose stools that go along with it. What's one of the few times that I'm going to talk in just a moment about dealing with the GI upset with metformin? Um, Something to keep in mind. When do we consider discontinuing metformin is when the estimated GFR is less than 30, frailty and advancing age because of the increased lactic acidosis risk. Now, the lactic acidosis risk with metformin is really, really low, but it can have up to a 40% mortality rate. Low cost option. So when the students come back and say to me, oh, so we have to memorize drug costs, I'll say, no, but what's important to remember is metformin's been around for more than 40 years. When something's been around for more than 40 years, it generally is cheap. And first line medication, if no contraindication, that's a compelling indication, which is one of the categories ADA wants us to consider. Now, here's something else to consider on this one. Is there evidence of improved cardiovascular outcomes with metformin use? Yes, there is. Yes, there is. Are there benefits of even perhaps preserving renal function with the use of metformin, largely through improved glycemic control? Absolutely, absolutely. So we don't have the fancy brand new studies on this like we do on a lot of the other meds, but that's because it's been generic for decades and no one's going to fund those studies. So I hear most people don't tolerate metformin. Okay, teachable moment. Is an adverse effect from a given med a contraindication or is it manageable? I've had patients come in and say to me, I can't take metformin, I'm allergic to it. So then you find out, again, another teachable moment. What do you do if somebody says they're, quote, allergic to anything? What happens? Oh, I get some stomach cramps and a little bit of diarrhea. Okay. And so in that case, that is a known manageable adverse effect to metformin. So prescribing tip, the lower GI upset, it's interesting. It's hardly ever upper GI upset. People will not say, ooh, the metformin made me want to throw up. No, 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 no. It's the lower GI stuff. As I said, the drug has prebiotic qualities leading to an increase in gut flora, in improving gut microbiome, because it helps the prebiotic qualities of metformin help increase the amount of these short chain fatty acids that then produced improved gut motility. So what do you do? First of all, in my exam room, no one ever gets immediate release metformin, ever. It's one of my few absolute evers. Never, ever, ever do I give out immediate release metformin. The extended release, which is cheap, it's available 500 milligrams per extended release tablets, 120 tablets per month on the $4 drug list that allows titration up to the recommended 2-gram dose of metformin. And that is another thing when people say, oh, the metformin didn't seem to work on this patient. It worked to do what it could. It insulin sensitized. And if the person's still not at A1C goal, then you need insulin release and or glucose offloading. So yeah, metformin alone isn't going to control blood sugar on people presenting with A1Cs of like 10. It's not. But Start slow, 500 milligrams XR daily for a week, then advise up to 2 tablets a day as the gut tolerates. It might take 2 months to get to the maximum recommended dose. And the reality is, it needs to be taken on, or it should be taken with the largest meal of the day. And I find that I've had some patients that it has taken them 4 months to get up to 2 grams a day, but they got up to 2 grams a day. And I always warn people, metformin's a big pill because sometimes that frightens people and they think big pill means I'm really sick. I always warn them ahead of time that it is a good sized pill. Now, are there 750 milligram XR tablets and other doses? Absolutely, absolutely. But this is kind of a quick and dirty way of prescribing it where you know the patient's going to get it for $4 a month. Can you tell that my practice has been in the lowest income urban neighborhood in a 6-state region? Yeah, so I'm always looking for this, is how we can save the patient some money and help the healthcare system um, save some money too. I had one patient who got up to, she really couldn't get beyond the 1,000 milligrams of XR once a day. So I said to her, are you willing to split it twice a day? And she said, oh, yeah, I'll give that a try. So she always ate a decent sized breakfast. She always ate a decent sized dinner. She took 2 in the morning, 2 in the evening. Great. Okay. And then one time she came in to see me for a visit and she started to cry. And I said, what's going on? And she said, I lost control of my bowels the other day at the hairdresser's. And I said, what happened? And she said, I don't know. I ate my breakfast, I took my metformin, and then all of a sudden, I've never had this happen before. So what she had done, which was really kind of scary, she discontinued every single one of her meds because she thought it's one of the meds. So thankfully, she had brought her meds in with her. And what the pharmacy had done was given her 1,000 milligram immediate release metformin. And it had literally gone right through her, right through her. So just that's a rather extreme example, but it gives you an idea of what can happen. So according to the ADA guidelines in type 2 diabetes, and remember, you've got our permission to share all of these, according to ADA guidelines in type 2 diabetes, which of the following is correct in metformin therapy? One, metformin should be continued as long as tolerated and not contraindicated. Two, if insulin is required for glycemic control, metformin should be discontinued. Three, metformin and pioglitazone should not be used concurrently. Four, there's an significantly increased hypoglycemia risk with metformin use and prediabetes. So which one's correct here? And the only one that's correct here is number one. And the most common reason to discontinue metformin is that low GFR. But this I often get asked. The patient needs to go on insulin. Do you continue the metformin? Absolutely. Can you use metformin and pioglitazone together? Yes, it is a beautiful combination for younger folks with type 2 diabetes, with acanthosis nigricans, who are clearly still making a lot of insulin, but they're not using it well. And it is highly advocated by ADA for prediabetes, and that it is tremendously underutilized. So this is another comment. I heard TZDs are dangerous. Why should I prescribe a medication I've never seen started, but have seen discontinued in the acute care hospital? And teachable moment, seldom is a drug all or none. After I just finished saying something was all and none in my exam room, that I never prescribe immediate release metformin. Well, that's just a form of a given med. But when we look at it with the TZDs, there's really only one left on the market that's utilized, and this is pioglitazone. Again, high efficacy will bring the A1C down by 1 to 2%. Low hypoglycemia risk because it has nothing to do with insulin release. Weight gain is weight impact, modest, a little bit of a weight gain. One thing that pioglitazone will tend to do is increase circulating volume. Not by a lot, but by a little bit. So a 35-year-old with a normal left ventricle is going to do fine with it. A 78-year-old with some occult cardiovascular disease is not going to do so well in it. And that's why there is that heart failure risk. And that's why you will see the folks transitioning from being acute care RNs to outpatient NPs, which most of them are training to do that. They're family and adult gero primary care, that they see pioglitazone discontinued but really never started. Don't use with nitrates or insulin due to the cardiovascular risk. It increases the circulating volume way, way, way too much. Low cost option, compelling indication, minimal hypoglycemia risk, and low cost. So let's take a look. Is there anything good to say about the TZDs other than glycemic control? And this was an article that was published in the Journal of Cardiovascular Diabetology just a few years ago, saying we need to rethink pioglitazone as a cardioprotective agent. And this is a quote from it, is pioglitazone use is consistently associated with reduced risk of MI and ischemic stroke and both primary and secondary prevention without any proven harm to the myocardium. Moreover, it reduces atherosclerotic progression, in-stent restenosis after coronary stent implantation, progression from rate from to permanent atrial fibrillation and reablation rate in diabetes patients with paroxysmal atrial fibrillation after catheter ablation. So pretty good to think about it. This is a great learning exercise that I find people just grab into it. Who is a TZD candidate? Yes or no? Okay, 30-year-old, type 2 diabetes, hypertension for the past 2 years, BP 122 over 78, so that looks good. Normal cardiac exam, currently on 2 grams of metformin daily. A1C is 7.9. And the way a board question would pop up with this would be like one of the choices would be, oh, his A1C's fine. We don't need to do anything else. Okay. He's on ACE inhibitor and hydrochlorothiazide, no health insurance. So obviously we know his A1C needs to be less than 7. And so is he a good TZD candidate to keep it on the cheap? And the answer is yes. Plus, we know there is likely some long-term cardiovascular benefit to the use of the med. An 80-year-old with LVH, 25 years history of type 2 diabetes, on basal and bolus insulin, his A1C is 7.9. We're going to try him, bring his, add a TZD, bring his A1C down some more. And the answer is a resounding no. Due to age and LVH, high risk for heart failure, no TZD, particularly with insulin because of the increase in the circulating volume and in the heart failure risk, plus an A1C of less than 8 is perfectly fine for him. The last thing we want that person to be is hypoglycemic because it could trigger a cardiovascular or cerebrovascular event. All right, now we're going to switch gears and go to the insulin releasers. So the first one, the sulfonylureas, glipizide is the most commonly used. And this is what I call dumb insulin release. Because what a sulfonylurea will do is say to the pancreas, oh, the blood sugar is 80, still release insulin. Oh, the blood sugar just went up to 220 after eating fairly carb-loaded meal. Yeah, just keep releasing the insulin. So it is an unsmart form of insulin. It's pretty good at bringing down A1C, and the hypoglycemia risk is moderate to high because of that unsmart insulin release. Weight impact usually modest, just a few pounds weight gain. But remember, anytime you improve glycemic control, you often do have a little bit of weight gain because this person is no longer in a ketotic state. Adverse effects, hypoglycemia, low-cost option. That's cheap, $4 drug list, and the only compelling indication is its low cost with all that worrisome stuff before. DPP-4 inhibitor, sitagliptin, is one example that happens to be trade name Januvia. And this was the first smart insulin releaser that came to market. And the effect on A1C is intermediate, about 0.7%. It's just not as potent as the other meds that I've just rattled through. But remember, it often is an add-on med and it's not the solo first line med, so that might have something to do with it. Low hypoglycemia risk because it's smart insulin release. So I make it sound like the drug is talking to the pancreas. All right. Hey, pancreas, blood sugar just went up to 220. We need some more insulin. Pancreas goes, okay, we'll release enough insulin till it's brought down to the blood sugar is brought down to a more within normal limit range. Weight impact, weight neutral. And here's one of the things with the DPP-4 inhibitors. This is about as good, as well tolerated a drug class as one will ever find. GI upset rare, no hypoglycemia, etc. Now, cost consideration is higher, but not highest, because these are tumbling to down in price as they've either all pretty much become generic or they're soon going to be generic. And compelling indication, minimal hypoglycemia risk. Now, you'll hear people kind of diss the DPP-4 inhibitors and say, yeah, but we don't have the cardiovascular benefit studies that we have with the GLP-1 agonist or the renal protective effects that or the renovascular benefits that we've got with the SGLT2I. You know, you're right. You're right. But it's a well-tolerated PO drug. I find there is still a place for it. So here is a question, and this is a perfect example. 81-year-old woman presents for follow-up. Her health issues include a 30-year history of type 2 diabetes, current A1C 7.8%, stage 4 CKD, with her current GFR is 28, and well-controlled hypertension. Her current meds include metformin, lisinopril, glipizide, and rosuvastatin. She lives alone in a single-level apartment and states, I can get around in my home with my cane. I'm a little less certain on my feet if I don't use the cane. So you know what she's telling us? She is telling us, I am one gigantic fall risk. That's what she's telling us. So the last thing you want to do is make her hypoglycemic. So which of the following should be considered, yes or no? Due to CKD, the risk of adverse effects with metformin use is increased. And this is a yes, because her GFR is down in the below 30, and I would discontinue it. Her diabetes therapy should be intensified with a goal A1C of less than 7%. Oops, sorry about that. And the answer there is no. Her A1C is just below 8. That's perfect. Leave her be. Leave her be. And a DPP-4 inhibitor should be used in place of a sulfonylurea. And yes, because she has that risk of sulfonylurea-induced hypoglycemia. You dig a little bit deeper, you find out, some days she eats lunch and other days she's just not that hungry, so she's got access to food, but she just picks at a couple of crackers at lunchtime and calls it a day. So this is a case study that I find really, really rings through with people. And of course, I have to throw it in, which I'm jumping ahead. With the stage 4 CKD, she is a great SGLT2I candidate as well. That would be something to consider. All right, so now we're going to, I'm lumping together the GLP-1 agonists like semaglutide, Ozempic, and the GIP, GLP-1 agonist, the example there being tirzepatide or Mounjaro or Zepbound when it's used for weight loss. And by the way, the difference between the doses of these drugs for diabetes and the dose for weight loss is the weight loss doses are generally higher. So mechanism of action, insulin releaser, but only post-glucose rise, so smart insulin release. High amount of A1C reduction. These two are simply the strongest at reducing A1C. The only drug class that's stronger than this is insulin. And that you could see 1 to 2% for the GLP-1 agonist and 2 to 2.3% for the GIP GLP-1 agonist. Hypoglycemia risk, very low because this is smart insulin release. And something that I will often mention when I'm teaching this with students is to say, when you're considering drugs with hypoglycemia risk, ask yourself, would you prescribe something like a sulfonylurea to a person who is an RN who works rotating shifts and eats catch can? And they'll say, oh, no, because you never know when you're going to eat. But if you were dealing with the RN who had type 2 diabetes, using one of these meds, using a DPP-4 inhibitor, you don't have to worry about the fact that people eat catch can. My practice is awash with people who are in work in warehouses and are on rotating shifts and things like that. Now, this is the drug class, suffice to say, where there's a huge impact on weight. I would say it goes beyond being modest, and there is weight loss. But usually, when you read about a med for diabetes having weight loss as one of the benefits of it, it's usually a very modest weight loss. This is a significant weight loss. So, adverse effects. GI upset, because how do these work? By slowing gastric emptying. One of the many reasons that they can suppress appetite is through slowing gastric emptying. So therefore, a little bit of food hangs around longer. And that's one of the major contraindications, is don't use in gastroparesis, which is neuropathy of the gut. And those folks with type 2 diabetes, or even type 1, who have numb hands and numb feet, invariably have a numb gut, and they oftentimes don't tolerate these drug classes. And I was just teaching a group of NP students not long ago about this, and they said, oh, well, for the nausea, why don't we just give them Zofran or something like that? And I said, no, the way you treat the GI upset is by pulling back the dose, let the body get used to it. And that's why there is a slow titration up with both of these drug classes. High cost, these are very expensive. Compelling indications, minimal hypoglycemia risk, weight loss. The GLP-1 agonists, there are demonstrated benefits for use with ASCVD and CKD. Those data are emerging for tirzepatide as well. Now, glucose offloader, and the example here is the drug class with the gliflozin suffix. So like canagliflozin is one of these. And mechanism of action, it causes glucose offloading via kidney excretion, post-glucose rise. Intermediate effect on A1C. Hypoglycemia risk is low. Weight loss. Now, this is one thing. You'll hear about this being helpful in weight loss, but here is the bottom line on this. The average person on an SGLT2I pees out 200 sugar calories a day. 200 sugar calories a day. And if you add that up over time, and a pound of fat is 3,500 stored calories of fat. If you do the math, people will lose a little bit of body fat by being on this drug class, but it is not like the GIP, GLP-1 agonist, nothing like that. But very often when people go on this drug class, they lose like 5 pounds in a week, 5 pounds in a week and a half, something like that. And then it slows. And the reason for this, the reason for that quick weight loss is this causes offload of water with the sugar. So how does the sugar leave the body? It takes water with it, or the water forces it out, whichever way you want to look at it. And this is something that we do need to keep in mind. That leads to the adverse effects. This is a great example of adverse effects being consistent with the drug's mechanism of action. And so this can be a mildly dehydrating class of drugs. You know what group of people you need to be really, really careful with the SGLT2Is? Older adults who don't, in particular, have some mobility issues, maybe some little bit of bladder control issues. They don't have a big thirst drive anyway because of their advancing age, and they're drinking very, very little in the first place. Then you give one of this drug class, what you can end up with is some lightheadedness from dehydration. And the sugar is going out someplace. It's going out through the urinary tract, so there is increased UTI risk and increased risk for genital candidiasis. This next one, avoid initiating with an estimated GFR of less than 30. Again, put a little asterisk next to that because nephrology is crazy about this drug class. And I see them saying, yeah, the GFR is in the high 20s, the person's doing okay. Maybe we leave them on this because of what we know about the helpfulness in CKD. Cost, high cost, and compelling indication, proven benefits with ASCVD, heart failure. There's actually an SGLT2I on the market now, labeled specifically for people who don't have diabetes but are in heart failure. It's pretty amazing. Minimal hypoglycemia risk and that modest weight loss. So, which of the following meds is demonstrated to have cardiovascular benefit among patients with type 2 diabetes who have established ASCVD? The SGLT2Is? Yes. The GLP-1 agonists? Yes. The DPP-4 inhibitors? No. But they have low hypoglycemia risk. So, but there's no specific cardiovascular benefit. The sulfonylureas? No, and they're really problematic due to their hypoglycemia risk, particularly in cardiovascular disease. And to drive home the point that most med questions are safety questions is really, really important. And I don't want to make it sound like the only thing that I care about or you care about is people passing boards. However, how do you often catch students' attention the best? By reinforcing that. So, with type 2 diabetes, which meds have been shown to reduce the risk of CKD progression, cardiovascular events, or both? And so it's the SGLT2Is and the GLP-1 agonists. All right. Now, when should you use insulin in the treatment of type 2 diabetes? Well, let's just stand back and say diabetes in general. Type 1, all individuals with the diagnosis, because of course, this is a disease of profound insulinopenia. What does the healthy pancreas do? The healthy pancreas in the person who does not have type 1 nor type 2 diabetes makes about 50% of the body's daily insulin as a basal and 50% in boluses in response to glucose rise post intake, post meals, and with snacks. So basal bolus with these adjustments via either multiple injections or, of course, now with type 1 diabetes, increasingly with insulin pump. Couple of things with type 2 diabetes. This has long been a recommendation by ADA, is that if the patient presenting with type 2 diabetes at the time of the diagnosis and the A1C is 9 or higher, particularly if they have symptoms like the classic polys, visual changes, and others, to start them on a short course of insulin to help achieve normal glycemia because that hyperglycemia induces insulin resistance and really impairs pancreatic beta cell production or pancreatic beta cell function, I should say. So it kind of stuns those pancreatic beta cells. So with insulin, is there a pharmacodynamic difference with insulins? In other words, what the drug does to the disease. Is there a pharmacodynamic difference with insulins? No, insulin is insulin. However, is there a pharmacokinetic difference with insulins? Oh, yes, because peak of action, duration of action, onset of action is all really important. What's the most likely adverse effect when insulin peaks? And it's going to be, of course, hypoglycemia. Hypoglycemia. So, what about now with insulin and type 2 diabetes, other than a couple of weeks worth at the beginning of therapy to bring that initial A1C down a little bit? And if time allows, we can go into how that can be done in a relatively streamlined manner. Is when two or more injectable, oral or injectable agents, particularly drugs that enhance insulin release, like the sulfonylureas, the DPP-4 inhibitors, GLP-1 agonists at optimized dose are inadequate to maintain glycemic control. And I find this is a great exercise to work through with people. So, what is the body telling you? If the A1C, the glucose, is still too high, and they've tried a sulfonylurea and or a DPP-4 inhibitor and or a GLP-1 agonist or a GIP GLP-1 agonist at optimized doses, and they still can't maintain glycemic control, it means the beta cells are not working well anymore. It's as simple and as complicated as that. So this is, I've given you a great resource here. I know it's way in the bottom of the slide, but it's open access and it's from 2018. It's not that old, but it is a great resource for the use of insulin in type 2 diabetes. So, deprescribing principle. Don't continue unwise practices that are seen daily in clinical settings. And this is something that I find throws people is that for a number of years, the ADA has been saying sliding scale insulin therapy treats hyperglycemia after it has occurred instead of preventing the occurrence of hyperglycemia. This reactive approach can lead to rapid changes in blood glucose level, exacerbating both hypo and hyperglycemia. And our students come out of mostly the acute care setting. They see what they label as sliding scale insulin, which is more correction insulin in the acute, more correctly called correction insulin in the acute care setting. Then they get out in primary care and they're seeing a patient with type 2 diabetes who is reporting, you know, episodes of hyperglycemia after eating. And then they'll say, oh, okay, well, if I was in the hospital, we would put this person on sliding scale insulin and we would take care of it that way. And that, of course, is incorrect. And that it is a really, really dangerous way of treating hyperglycemia. Terribly, terribly dangerous. I had a patient of mine, an older woman, well into her 80s, who was on insulin, basal and a bolus, and actually doing pretty well in the day to day. She had a very attentive family, lived with a number of family members. One of her daughters, who was really just wonderful to her mom, gave her all her meds and everything. And her A1C was, like around 8. We were all happy with that because she was of more advanced age and a little bit unsure on her feet and wanted to avoid hypoglycemia. And then all of a sudden she's hospitalized and she's back out in the community and her blood sugars are just all over the place. Plus, she had a couple of episodes of hypoglycemia. And I'm seeing her after this hospital visit, and I said, something is not adding up here. What's going on with her insulin? And the daughter pulls out a photocopy of an insulin correction scale from the hospital and said, oh, one of the nurses gave this to me. So that's how I'm giving my mom her insulin now. I'm not giving it to her before she eats. I let her eat, then I check her blood sugar, and then I take it from there on how much insulin to give her. And I was like, oh, please do not do that. Please do not do that. So you want to avoid this in the Beers criteria, also due to the risk of hypoglycemia without improvement in hyperglycemia management, regardless of care setting. So whether it's in the hospital or out of the hospital. And that the sliding scale, just a reminder, it refers to as the use of short or rapid acting insulins to manage or avoid hyperglycemia in the absence of a basal or a long acting insulin. And it does not refer to titration of basal insulin use or the use of additional short or rapid acting insulin in conjunction with scheduled insulin, i.e., correction insulin. So let's take a look at a few things here. Teachable moment. So this is a guy who's not at A1C goal, and we need to consider cost and hypoglycemic risk. 35-year-old man with a 1-year history of type 2 diabetes and current A1C of 7.9% is in the office. He's taking an optimized dose of metformin with adherence, works rotating shifts in a warehouse where he grabs something to eat as time permits. So what do we hear here? Catch as catch can diet. Catch as catch can. Sound familiar? Yeah, his health insurance recently changed and he states, I have a really big copay. So that is something that should make the reader of this question say, all right, we need to avoid really expensive meds. The next step in his type 2 diabetes pharmacology should include A, a sulfonylurea, B, a GLP-1 agonist, C, a TZD, D, no med adjustment as he's tolerating his current meds. Well, what's the teachable moment here? He's not at A1C goal. We need to consider cost and we need to avoid hypoglycemic risk. And the other thing, he's younger. So he's a great candidate for a TCD. It's going to bring him right down. His A1C is not that high. And if he's 7.1 on optimized metformin, let's cut the difference. That means he probably was like 8.9. He was probably in the low nines when he went on the metformin. So that's actually done a good job with his sugars, but his sugar's still not at goal. But this addresses safety, it addresses efficacy, and it addresses cost. Okay. So, okay. And a 56-year-old woman with a 3-year history of type 2 diabetes and obesity, she says she really feels like she's ready to work on my weight. She has a history of recurrent genital candidiasis and UTI. Her current A1C is 8.2%. So she desires weight loss. Her A1C is too high and that we want to avoid adverse effects. So, what would be the next best step in her treatment? So, would it be A, glipizide? Well, that would probably bring her blood sugar down to her A1C down to a more reasonable range. But does it address the weight? No, it doesn't. And is a sulfonylurea, would it be contraindicated in the presence of recurrent genital candidiasis and UTI? No, but it doesn't address the big thing here, which is weight. Option B, canagliflozin, an SGLT2I. Well, would this help with weight? Yes, as I had mentioned before, very modestly, very modestly. But what's the problem? The extra sugar is going to go out via her urine, and it could worsen her risk of recurrent genital candidiasis and UTI. So not a great choice. C, semaglutide, a GLP-1 agonist. Yeah, that's the best answer because that will give her the most weight loss. Plus, she's verbalizing that she feels like she's ready to work on her weight. So, and there's nothing mentioned here about insurance. So, one of that you would consider that. And then pioglitazone, a TZD, it's not going to help with the weight. It could help with the A1C. It's not contraindicated in genital candidiasis or UTI, but it's not the best choice. So C is the best answer here. And a 78-year-old man with gastroparesis and a 25-year history of type 2 diabetes is using metformin with adherence. He mentions, I've used glyburide and sitagliptin in the past, and my blood sugars just don't come down. So this is the teachable moment when you have to go back and remember how does glyburide work? How does sitagliptin use? Glyburide is a sulfonylurea. It's an insulin releaser. Sitagliptin, DPP-4 inhibitor, insulin releaser. Okay. He's on 2 insulin releasers. He has not had improved glycemic control. ADA says now we need to think his pancreatic beta cells are not working and we need to go in another direction. So, and his A1C is 9.2% with elevated fasting and post-meal blood sugars, which is the best advice in his type 2 diabetes treatment. Would it be a GLP-1 agonist? Well, that is the most potent of the insulin releasers, that along with the GIP, GLP-1 agonist. But he has one of the few contraindications to this drug class, and it's the gastroparesis. Would you try him on a TZD? Oh, no, 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 because he is the person that this could tip a TZD with the extra circulating volume, could tip him right into heart failure. Basal in mealtime insulin, yes, because he has failed therapy with 2 insulin releasers. So the guidelines are 2 or more insulin releasers, okay? And then looking at D, no adjustment in therapy is his A1C is at age appropriate goal. No, no, his A1C is too high. It's at 9.2%, right? A 55-year-old man presents as a new patient to your practice. He reports a 10-year history of type 2 diabetes with stage 3A CKD, dyslipidemia, and hypertension. His current meds include metformin, atorvastatin, candesartan, and clothalidone at optimized doses and with adherence. And he's generally feeling well. So, yes, he's got type 2 diabetes, but what's the other big one here? He's got stage 3A CKD. His current A1C is at 8.2%, and his GFR is at 45. So that's where stage 3A CKD would be kind of hanging out. So when you look at this, another really important point is, I'm going to go back a slide. No, he doesn't need to have his metformin discontinued because his GFR is way above 30. By the way, the statins can be given down to GFRs of 15, and they're okay to use. And so the next step in his type 2 diabetes pharmacologic therapy should include a sulfonylurea. Well, you know what? This is in the current thoughts on prescribing meds in type 2 diabetes, is that whenever we can get, shall we say, a 2 for the price of 1 out of a med, improve glycemic control, plus treatment of a comorbid condition like CKD, we want to do that. So the sulfonylurea could bring down his blood sugar, but who do you think is more likely to develop hypoglycemia on a sulfonylurea? A younger adult with a GFR in the 70s who's on a sulfonylurea, or a middle-aged man with a stage 3A CKD who's going to hang around with hang on to that sulfonylurea for a long period of time. Obviously, it's going to be the a person like this, who the sulfonylurea is going to hang around for a long time because his GFR is down. And if he was to take a sulfonylurea and become hypoglycemic, he's going to be hypoglycemic for hours, if not days. And because the med will just hang around for a long period of time. Okay. B, an SGLT2I. Would that be a good choice? And that's our best answer, clearly. C, a DPP4 inhibitor. Well, that would help perhaps improve his glycemic control, but it's not going to do anything for his kidneys, which we want to preserve. He's not that old a man. And no medication, option D, no medication adjustment as he's feeling well. No, because his numbers are off. He's got a comorbid condition. Something needs to happen. And I find when I'm talking to folks whose knowledge of pharmacology is on the low side, they'll often go for an option like no med because he feels okay. Because what they'll go is like, well, why mess around with the patient, change their meds if they feel okay? And it's ignoring the pathophysiology that's going on in there. So remember, when prescribing, confidence is built, it is not born. So I want to thank you for your time and attention. And I also want to thank you for the little bit of the late start we got off to today. There was a little confusion on my end on the starting time. And how about we take some questions and comments? And I would ask you to put your questions or comments into the Q&A box. And if you're wondering where that is, it's way over to the right. There'll be three dots there, and hit that, and then you'll see the Q&A box open up. And by the way, I just got back from AANP where I swear I saw as many NP faculty at AANP as I did at NONF in April. It was wonderful. It was a lot of fun seeing a lot of familiar faces. So ask away. And I believe you've received the information on getting your certificate. And so make sure you do that because we want to make sure you get your CE.
So I posted that for them in the chat.
Great, thank you.
You're welcome.
All right, if there are no questions, then we can wrap this up. The way this is set up, I unfortunately don't have the ability to answer a raised hand, but let me just double check and see if anything came in on the chat. Doesn't look like there are. Okay, good. One question came in here. No questions, but thank you for your dedication to NPs for so many years. Oh, that's so sweet. Thank you. That means a lot to me. I had people come up to me at AANP who took boards with me 20, 25, sometimes 30 years ago. And then sometimes just a week and a half before that. So it was really rewarding to see that. If sliding scale is not recommended, what would be the alternative? If you go into that article that I gave you the citation for from the AAFP journal, it will give you some great advice on that. And what it is it is the concept of correction insulin. So if I was to, okay, this is kind of a quick example, right? A person normally uses 8 units of a rapid acting insulin before meals. But this person also right now is recovering from pneumonia. Okay. In other words, their body is stressed. So they use their 8 units before they eat, but 2 hours post, and maybe they don't eat quite as much as they usually do because, again, they're recovering from pneumonia. They're not feeling quite themselves yet. Okay. So then what you do is 2 hours after meal, the glucose is out of range. Then a couple of more units of insulin is used as a correction insulin. So that's an example of how there is a difference between a sliding scale and a correction insulin. So let's just say an extra 2 units of insulin took care of that post-meal hyperglycemia. So the other way to look at this would be to say, oh, okay, skip your pre-meal insulin, eat, and then 2 hours later, oh, look how high your blood sugar is by some quote sliding scale. It says give you 10 units of rapid acting insulin. Can you see what a mess that patient could have gotten into with hypoglycemia? Okay. So that's what you want to do. And you know what? There are a whole bunch of different scales that you could use, or I shouldn't say scale, resources. MD Calc, MDCALC is a great app. And they have a correction insulin scale on that. That's evidence-based and all that good kind of stuff. And the other part of it is somebody might say, well, correction insulin sounds like sliding scale, just delivered a little bit differently. No, it really isn't. It really isn't. And what we need to do is try to remove the language of sliding scale out of people's vocabulary because it really is quite dangerous. Okay. So if there are no other questions, we'll wrap the evening up. Thank you so much. I hope to see you next month. And I believe next month we're doing hypertension and dyslipidemia, another area where people have a lot of questions. And then the one after that is antimicrobials, another area where people struggle. So thank you so much. And thank you, Stephanie. Take care. Good night.
Thank you. Good night.